Welcome back. You know, you all are so quiet, I didn't realize the room had filled back up. But welcome back to the second half of the heart failure session. And it's really a great pleasure to have one of my other colleagues from Duke give the next talk. Dr. Eric Velazquez is an associate professor of medicine, a very accomplished heart failure clinician, an exceptionally accomplished heart failure clinical trialist. And if that wasn't enough, he was asked to wear another hat at Duke, and that is to be the director of the Echo Lab. So Eric has a vast expertise in the clinical management of heart failure, but also imaging heart failure. We've asked Eric to spend a little bit of time today talking to us about sort of the appropriate kinds of strategies for imaging the heart in people who have heart failure. Eric, thanks for coming.
Well, thanks, Joe, for that undeserving introduction. First of all, thank all of you for being here and for having me. As a disclaimer, I do want to just mention that heart failure is my first love, but imaging is an important second for me. And actually integrating the two has become a fun challenge for me personally as well as scientifically. Imaging in general, and particularly in heart failure, is somewhat of a data-free zone. And I'll say that in all honesty. It's not to say that we don't know how to utilize the modalities we have, but that we haven't focused beyond the development of information on sensitivity and specificity and comparative information between modalities on what should drive decisions, which is usually data-related outcomes. And although we've heard great talks so far this morning about clinical trials as they relate to heart failure and outcomes, that's going to be something that you're not going to hear a lot about from me because there's not a lot to talk about. I am proud to say that I think we're starting to do more of that work, and one trial, not in heart failure, I'll take an opportunity to mention, we'll be evaluating that we're working on, a 10,000 patient trial called PROMISE, that will be looking at different modalities with an outcome, different strategies of ischemic testing. So we're getting there, but we're not there. I think this will be a fun talk. I'm going to show a lot of images if they play, I hope, and try to give you a framework for how to integrate information about your patient as it relates to what types of tests are going to be useful. So my goals today are really to describe, differentiate the common cardiovascular imaging methods utilized in the care of patients with heart failure, and really to use a case-based review to kind of hone in on some pertinence. I cannot in any way cover in 30 to 40 minutes all the modalities and all the particulars about modalities that we use, but I hope this will allow us to have a discussion about which kind of imaging tests are best for which kind of patients. So what's our toolbox look like in heart failure in terms of imaging? It's really echocardiography and X-ray angiography or cardiac cath methods. You'll see that I've slightly changed the color of those two because I want to highlight that those are your two modalities that are real-time, continuous acquisition imaging modalities, meaning that when you put a probe on someone, you're actually imaging their heart right there and then, and not gating the information and reconstructing it, which is more consistent with how we use nuclear imaging, magnetic resonance imaging, and CT angiography, which are also important and have roles. But this distinction between real-time continuous acquisition information versus reconstructing data that's acquired is an important one as it relates to how the modalities compare to each other and what their pros and cons are. So why do we use imaging in heart failure? Well, clearly it is the way we approach the diagnosis. Patients present day in and day out to our offices, to our emergency rooms with dyspnea or lower extremity edema or some other component of the syndrome of heart failure. And the question is raised, is this heart failure or is this something else? And imaging is an approach that is, I think, it's probably the most common approach to kind of start pushing us down one pathway with regards to just the diagnosis of heart failure. Then the issue, which may have been raised earlier by Mike, but unfortunately I missed, the issue of classification and evaluation of etiologies. Imaging is what we use to actually define if a patient is ischemic or non-ischemic and to drive therapies. It also helps us understand if they have evidence of restrictive myopathy versus a more global dilated myopathy. So very important, and I'm going to share some examples. I think more and more we're using imaging to focus treatment options, to develop strategies of care that allow us to add or sometimes subtract medications from patients, and to give them advice around how they should manage their disease. Then defining prognosis, and here is where I think imaging is really well described. Defining the ventricle, how it's remodeled, what its hemodynamics look like on an ongoing fashion is probably one of its most important, one of imaging's most important goals. And more recently, we are using imaging to develop a strategy to evaluate responsive therapy and then change therapy or change device therapies and then recheck. And the imaging allows us to do that. So those are some general guidelines of why we would pursue an imaging strategy in patients. So I'm an echocardiographer. I do other types of imaging as well, but as Joe mentioned, I run the cardiovascular imaging program in our health system, but particularly focus my energy on echocardiography. And it's a good thing because I think echocardiography is the workhorse for heart failure. For those of us who care for patients, echocardiography is where it starts and sometimes where it ends with regards to how to evaluate and care for patients. What do we get from an echocardiogram? And I'm going to focus my later cases on and things that we get but we don't maybe recognize. But the common things we get are morphology. What is the ventricular shape? Is it dilated? Is it small? What is it the shape like a football? The shape like a volleyball? And then to look at morphological abnormalities. Is there some congenital abnormalities that we have to identify that would lead to a different strategy of treatment and referral? Ventricular function, I would imagine that is what people in this room, when they think about imaging and heart failure, they think of EF. Well, if I leave you with only one thing, please remember that you get more than an EF from an echocardiogram and from most of your imaging, and that information is very valuable beyond an EF. But EF is clearly an important defining characteristic of our heart failure patients, and we target therapies. Therapies have been developed to be targeted to different EF categories. Evaluating valvular disease at baseline and progression is critical. That's all types of valvular disease, including stenotic disease as well as regurgitant disease. Hemodynamics, we get a significant amount of information from echocardiography to evaluate our patients' hemodynamics, which is not typically utilized, but is there for the taking. Ventricular filling, issues around diastolic compliance, important. More and more, we're providing information, at least in our lab, this has become systematic, and we are acquiring information on myocardial mechanics, deformation of the myocardium, so-called strain rate imaging, to provide some information on how do we target new therapies and how patients may be progressing. And then I put this in italics because I think it is really still a research tool, though some would like to think otherwise. It is issues of perfusion, and you can use echocardiography with different perfluorine or other compounds for perfusion. I'm not going to mention much more about that. What about the cardiac cath and X-ray angiography? Well, again, continuous acquisition, real time, and really the gold standard for evaluation of coronary arteries and cardiac veins. I mentioned the cardiac veins because sometimes is forgotten, and for those of you who are involved in cardiac catheterization or who send patients to them, it is probably becoming even more important to do the levo phase of a cardiac cycle and to understand how blood, the dye flows back through the cardiac veins back into the heart after it's injected. And we always focused on the cardiac arteries, but now when we have devices that we can implant in veins to change how we manage our patients, understanding that morphology is important. Obviously, this is something that echo can't give you, but angiography can give you information about LV function and hemodynamics as well, and that's very important, and I think probably for hemodynamics the gold standard. Nuclear imaging. I'm not going to show much pictures, but maybe it will be a good opportunity to review some maybe there will be questions related to this. This is a very common, probably I would say the most common approach to ischemia evaluation in the U.S., looking at using SPECT profiles to look at myocardial perfusion and ischemia to assess for viability, whether or not that's important. We don't know, but that's something that has become part of our approach to patients with coronary artery disease. And then more and more metabolic imaging. And then cardiac MRI. This is a really exciting, I'm going to show you a few cases, really exciting option for patients in terms of trying to understand tissue characteristics, etiology. Sometimes can be combined with perfusion imaging to get more bang for your buck, so to speak. Really, my preferred approach to identify, define congenital heart disease and for any anomalous vascular connections that you might expect. It's a really detailed morphology and reconstruction. But this is something that probably can't be repeated routinely, may not be available everywhere, and is limited, frankly, by some things related to renal function because of the dye that's used sometimes for hyperenhancement procedures, which I'll mention, as well as the issue of you can't put metal in the machine. So if you got metal in a pocket over here, which many of our patients do, that becomes a challenge. Just to step back and just kind of highlight a topic that's been a work that's really been done by a very exciting group of ours at Duke. The issue of hyperenhancement with gadolinium has become part of our, I think, approach with the use of MR to understand tissue characteristics. And I thought it was important to just define this because it may be something that people are not as aware of. And I think the data is, again, it's basically qualitative data, not as quantitative, but there have been definitions based on gadolinium enhancements of types of hyperenhancement and patterns of hyperenhancement that give you a clue with regards to etiology. And so it's really based on the concept of the wavefront phenomenon that was identified actually back at Duke by some pathologists, cardiovascular pathologists in the 70s. The concept that the myocardium after a coronary occlusion dies from the endocardium out, and usually along a territory, a distribution of the coronary artery. And so for the concept here is just highlight, I'm going to point on this. If you use hyperenhancement techniques, you can actually differentiate an area that hyperenhances or gets brighter on certain types of MRI imaging towards the endocardium, which would be more consistent with a subendocardial infarct, versus a more global wall transmural infarct that you would see maybe after an ST elevation without reperfusion. That's different than what we have found with more non-ischemic or non-coronary disease type patterns. And this is more actually focused on issues that are cardiomyopathies that are associated with replacement collagen or replacement fibrosis. But there are different patterns, and you can see, a pattern that suggests that the endocardium is preserved and the epicardium is preserved, but it's all mid-myocardial. Well, that's not likely to be due to a coronary event. That doesn't make a lot of pathological sense, and it's been shown to be a differentiator, this pattern, relative to this pattern. And then the issue of maybe in multiple places along the epicardium or in a patchy distribution are all things that suggest a pattern that would point you towards a cardiomyopathy that was maybe more infiltrative than the more traditional, more common coronary disease pattern. And actually, the lack of a pattern is also very important too. So if you have no hyperenhancement, that can be used more and more to define lack of permanent involvement or fibrosis of the myocardium.
Eric, can I just stop here for one question? This is a fascinating topic, this notion of being able to very carefully see the amount of scar in the ventricular wall. Can you tell us a little bit about how that may be related ultimately to a patient's prognosis, i.e., if you see more scar burden, is the patient more likely to have a shorter survival? Are they more likely to have arrhythmias? What do we know about that?
So I'll point to two examples to try to answer your question. I'm not sure I can answer completely, but I think in the CAD population, this group here, the amount of scar, and this has been defined as scar. It's actually been done pathologically as well, and it's basically replacement fibrosis that hyperenhances. The amount of scar is much more accurately quantifiable using this technology than, for example, for echo, which I would argue can't right now, and by other technologies. Is very closely related to prognosis. So the more scar you have, the more likely you're going to have a worse outcome. In terms of the non-ischemic, and I'll use sarcoid as probably the best example because it's work that I'm very proud of. One of our colleagues has done on MRI in sarcoid, Manesh Patel, has very nicely correlated the amount of scar and the pattern of that scar in a sarcoid patient to the risk of ventricular arrhythmias as well as the risk of mortal events. So I think there's a relationship there. I think it's quite strong. Is the data in thousands of patients and highly developed? Probably not yet. Let's just a few comments on CT angiography because I think it's the new kid on the block, so to speak, in a way. I think it's very fascinating. It's probably going to have a role. Its role in heart failure is still in development, I think, but critically we can see coronary arteries and coronary anomalies very nicely if you have that suspicion. It's in cardiac vein morphology as well, non-invasive. So that's a big issue for our patients who have multiple morbidity and multiple comorbidities, I should say, and have a risk of bleeding. We don't have to put them at that risk with this technology. I also think it's a great test for congenital heart disease, particularly in patients who already have metal in place that can't go through an MRI scanner. It's more and more being evaluated for those patients with low likelihood of coronary disease who would otherwise undergo coronary angiography but don't want to, because a clean coronary, so to speak, diagnosis on a CT angiography has a high negative predictive value, so it's a very important negative predictive value. And I think other things that we don't recognize and probably may be very pertinent to you in your hospitals, it's CT is done very routinely for other things, PE, dissection concerns. So providing that these images are acquired in a certain way and gated, we can get a lot of additional information if we can just focus our interest in that area too. And I think it can become a much more useful test because it is so commonly used for other indications. Let me mention a few comments about risks and repeatability, because I think it's important as you define what tests you want to pursue with your patients. There are procedural risks, and I think for the imaging that's focused on ischemia, particularly nuclear and stress echocardiography, where we exercise patients or use dobutamine, as well as particularly in our institution, nuclear adenosine imaging, as well as adenosine MRI imaging. They're provocative. There are risks related to that provocation that can't be ignored. And there are also certain technologies, particularly CAP, which are invasive and that may want to be avoided. And those are things that have to be put into your discussion of how to approach these patients which test. The dye. There are two studies, so two modalities that don't use dye, echo and nuclear, particularly. Dye, the kind of dye you worry about. Gadolinium, which is used commonly for MRI, has been associated with some problems in patients with renal dysfunction. And obviously the dye used in angiography, either CT or X-ray angiography, is associated with both an allergic response and renal dysfunction. So those are considerations. Radiation risk, I'm going to mention that. I didn't want to leave that topic before I spend a moment on it, and that's next. And then the limitations of the procedures. I mean, you can't, I mentioned it twice already, but I'll mention it again. You can't do an MRI on a patient who has metal in them. That's a limitation. You cannot repeat because of the radiation risk a cath and CT multiple times because you're maybe putting your patient at a little higher risk. So you may choose images or combinations of imaging modalities based on your goals for the patient at the point that you're at now, as well as your future goals. And then the issue, which I think is the biggest risk in imaging in heart failure, is misdiagnosis. And I think that's something that's ignored. But you need to have teammates on your heart failure team that focus on imaging. And imaging is a specialty that probably needs to be done. It should be understood by all, but at least evaluated, I think, by people who are trained in that. As a lab director, I'm becoming more and more. It's become more obvious to me about that point. So what about radiation dose? I mentioned here's just some the millisieverts are the risk. There is a background risk in the population of malignancies that's hard to distinguish between additional risk related to radiation. But you can see that clearly some modalities don't cause radiation, and some do. And nuclear has been traditionally thought to lead to the most radiation risk. And obviously CTA, depending on how you do it, is also up there. Cath, you don't do as much cath, may not, in patients repeatedly, and there is a risk for that. So there is a risk. It's hard to distinguish in an individual patient what the additional risk of a new study, another cath is. But if you take the population as a whole, it's a no-brainer. It's a clear risk to the population of additional imaging. Unfortunately, sometimes we don't have other options, and there are other risks we have to avoid. So I'm going to give you a few cases, and before I do that, I just wanted to use echo because I did say it's a workhorse, and I wanted to kind of focus on a few things that gets glossed over because we're always focused on the EF, and I just wanted to kind of mention a few things. I wanted to determine severity, just look at the mitral valve regurgitation, and just give you an example of the kind of imaging we can provide people and should become more and more standard. This is a normal mitral valve. It was a live 3D from a transesophageal position. You can see the quality of the imaging that exists now is actually quite nice, and we are able to show the commissures, the leaflets, the components of the leaflets. If we have patients who have abnormalities, like in this patient who has a posterior mitral valve leaflet prolapse, a P2 segment, we can define the actual segment and tell the surgeon this is what you want to really focus on. And I think this kind of information is relatively new for echo in the last, I would say, 5 to 8 years. It's becoming more routine and is no more difficult to acquire, frankly, than just regular traditional 2D echocardiography. With regards to MR severity, we need to do a better job. MR is clearly associated with increasing risk. We need to quantify and qualify MR severity well. There's many different ways of doing that. Basically, because of Doppler imaging, we can do with echo, we can quantitate instantaneous flow rates and stroke volumes, and we can use that to determine the extent of the regurgitant volume that goes back into the left atrium. And quantifying that over time is probably important, and also quantifying that in different hemodynamic conditions is important, because someone might show up and have no mild MR, and you're saying, oh, this is not a problem, but they go into flash pulmonary edema every time they exercise. Well, you need to exercise them and look at their MR, and maybe you'll find something that would lead to a different approach to the therapy. We use vena contracta. I'm not going to go into much detail. This is just an example of just measuring the narrowest portion of the jet. We use flow convergence methods, again, that have some assumptions built into quantification to understand the effective regurgitant orifice and the area of the flow backwards. We can measure the LA, and we should use that information to evaluate pulmonary vein inflow, atrial flow dynamics, dimensions. All that's been associated with bad outcomes. I'm going to go through this a little bit quicker to get to the cases. I don't want to lose time for this. But just to understand, there are different information provided to you by the pattern that you get from Doppler in the echocardiogram to look at pulmonary vein flow. That tells you a lot about the left atrium. You can understand what are normal atrial flow dynamics and what are abnormal, and maybe choose therapies based on that information. And measure the LA volume, which is basically the best manometer of filling pressures that we have. Maybe Mike would have a nice argument about BNP, but this is a chronic measurement instead of an ongoing measurement, and I think it gives you a good sense of how to It's like the hemoglobin A1C of LA filling dynamics for heart failure. We can measure our left atrial dimensions, and then the measuring the RV is something that people don't spend enough time doing, I think, and I think there's a lot of relationships to prognosis, understanding the volume and pressure overload, evaluating pulmonary pressures. Here, I'm going to spend a minute and say estimating RV systolic pressures and pulmonary artery end diastolic pressures in patients with heart failure gives you information you can act on immediately, and it's not invasive and can be repeated. And most of you know how to do that, but just looking at tricuspid regurgitation, estimating the peak velocity of that Doppler signal shift using this formula. And it's been well correlated with catheterization measurements. There are some sources of error that we have to be aware of. We also can do the same kind of calculation for pulmonary end diastolic pulmonary pressures using the same kind of strategy, looking at pulmonary vein regurgitation, pulmonary valve regurgitation, and then estimating the end diastolic pressure. And so with that, as an introduction, I want to take you through a few cases. I'll go through these pretty quickly. We can always stop, and I can review these cases in more detail with others. And I actually had many more, but I chose to limit. The thing with imaging is that the pretty pictures can be quite pretty, and you want to show them off. But I held myself back. It's a patient of mine I've been following for a long time, and I think Joe may know her as well. A 49-year-old woman who was referred to me by neurology from the ER after a TIA, and she had a left vertebral occlusion. And she had a history of ductal carcinoma of the breast and had mastectomy and adriamycin-based chemotherapy, but had been lost to follow-up. And as you may recognize, it's not really routine to evaluate LV function in these patients who are at high risk because of the chemotoxicity, and maybe that should change. But the patient was kind of lost to follow-up, but was really came in with basically a mini stroke. We did a transthoracic echo as part of our evaluation, and we found an LV function that was reduced, 35%, and diastolic dimensions that were dilated. I'm sorry, this was before I saw her, actually. In 2002, you see her EF was 50%, her end diastolic dimensions were normal. So then I get to see her, and this is what her heart looks like. So this is, again, just an opportunity for me to mention things that I didn't mention before. And echocardiography can give you information about ventricular function. There's an apical Ford chamber with this at the apex nearest where the transducer is, next to the chest. This is the left side of the heart, the right side of the heart. And the mitral valve, you can see here. And the heart, you would all agree, I hope, is enlarged and poorly contractile. This is a pulmonary vein, just so you're aware. We are able to identify the patterns of filling using parameters. This one I chose to show is deceleration times across the mitral annulus when the mitral valve is open. Gives you an information about the LV filling parameters and then during diastole, as well as the left atrial pressure. This suggested that deceleration times were quite short, so there was a long period of diastasis because of the rapid equilibration of pressure from the left atrium and the left ventricular and then diastole because of the high pressure she's under. So she has really restrictive filling pattern, which is, again, very important to her treatment. And looking at the tissue mechanics here, looking at the lateral annulus, you can see that the flow of the annulus doesn't move very much. And this is just 5 centimeters here. I can't read it very well there. But very low velocity signal of the annulus. This is her tricuspid valve. It doesn't run very smoothly there. It's going. A lot of tricuspid regurgitation. She was the Michelin lady. She was very edematous. And it probably related some part to this. You see her pressures. The gradient across the tricuspid valve was 48 millimeters of mercury. You add that to a right atrial pressure, which was quite elevated, and you get an estimate of her pulmonary pressures, which were quite high, clearly leading to some symptoms that she had. And she has a lot of MR, and that's going to run there. You see that all this jet area here in the left atrium is mitral regurgitation. Well, that's not helping her either. And we were able to quantify it, as I mentioned. I'm going to go through that. So at that point, her ejection fraction was less than 15%. Her LV and diastolic dimension, these remodeling parameters of diameters and volumes, enlarged volume and large diameter relative to a few years earlier. Left atrium was moderately enlarged, so restrictive filling. She had some TR. She had severe mitral regurgitation, which was well quantified there. And we did our best. We managed her acute decompensation. We got her volume neutral, but hypotensive, an issue that was raised already. Really only able to tolerate very low doses of ACE inhibitors discharged to outpatient clinic. And I don't know if I ever really got her on a beta blocker. Tried very time. Saw her every 2 weeks to try to avoid readmission, but was poorly successful with that. Persistent symptoms through the summer or fall. Multiple medication adjustments. You can see here we did take her to catheterization just to confirm because of her age that there was no coronary disease. So here the combination of multiple imaging modalities to kind of get to a decision about what the next plan is. And I offered her up as a potential transplant candidate because of where we were and the fact that we couldn't get her symptomatically in good shape. She had the breast cancer history, but it was many years out, so at least a discussion was had, and I think we made the right decision to go to CT surgery for mitral valve, tricuspid valve ring, to see if that helped, to try to avoid things. She continued to do poorly for a while, had a lot of lower extremity edema, but her ventricle didn't really change in size. And you can see the mitral valve ring and tricuspid valve ring here. The ventricle looks kind of crummy still. So I didn't feel too good at this point. But you know what? She started feeling better. Her ventricle didn't change too much, but her MR and tricuspid regurgitation were pretty much gone. You see that mitral regurgitation through a short axis. And she's had no hospitalizations for 18 months. She had an ICD implant. She was able to go back to work. She's able to do some activities. And her ventricle really hasn't dramatically improved, but her symptoms have. And I think it was information that was available by imaging to kind of help us guide what were our options. I'm going to go to the next case real quick before we can have some time for discussion.
Okay.
This is another interesting echocardiogram of a patient of mine who had a new diagnosis of heart failure, mid-40s gentleman, no previous history, no real triggers for heart failure. Came in and there's a couple things I wanted to use this case to describe. This is a loop, it's continuously acquired, but we only show you a few loops. And this thing right here is not something you want in your ventricle. So we just discussed Coumadin. We may want to talk about it again. This just gives me a time to say we have become more quantitative in echocardiography. We are able to do 3D image acquisition in real time that allows us to then quantify more than we've ever been able to do with higher accuracy and reproducibility the ejection fraction, and then compare that. Also look at the patterns of deformation, which don't look great there. And you can see in 3D reconstructions this thing there that's hanging out there. Well, this patient, we can argue about whether it was the right thing, but I could not Coumadinize this patient, so I did. And 18 months later, beta blocker, ACE inhibitor, he was evaluated and had no coronary disease. His EF is dramatically improved. He was able to confirm, because I knew what I was looking at and I had comparative imaging, to stop the Coumadin, because he wanted to start rock climbing because he felt so good and didn't want it to fall on his head. And there we are. Another case of using a different technology. This is MRI. And so this is a patient of mine, fortunate 35-year-old, unfortunately for the doctors, lawyer, who came into an emergency room, not ours, and actually had some chest pain, but it wasn't really fully evaluated. And I think the key point is this thinned out wall here that is something concerning. And you can see with hyperenhancement, you can see there is a lot of this white, bright noise here, which suggests that this whole area of hyperenhancement is endocardial, almost nearly transmural infarction. And that was, and there was nothing that we could do, and he's done well. 2 more cases, Joe, and I'll finish. This is a patient who is being followed by our lung group who has pulmonary sarcoid. And because of our work on an MRI hyperenhancement, it's become more commonplace for us to evaluate whether there's a cardiac involvement using MRI. Key points here is a cine loop of the MRI, and you can see the ventricle is pumping very nicely, doesn't look particularly enlarged. This is a view, a chamber view, just the same kind of idea. Muscle is working. There's no evidence of abnormalities. And then with hyperenhancement, there's no evidence of abnormalities within the myocardium, that patchy infiltrate that I was looking for. Here is a patient, unfortunately, 3 years later with heart failure symptoms. And the ventricle is not functioning as well. But to get to the point is, you see now all this patchy infiltration along the right septum, here in the lateral wall, and that is all consistent with basically patchy fibrosis. I bet you if we were able to get a biopsy needle into that spot, we'd have granulomatous inflammation. And this was something we couldn't do, I think, before, to confirm what our suspicions were and to define new strategies for treatment. Amyloid, similar thing. The ventricle is not functioning very well. There's a pericardial effusion. Here's the short axis, and then I'm going to show you the hyperenhancement. And here, a very consistent mid-myocardial, almost completely involvement of the amyloid that defines this as different from sarcoid, different from an MI, and gives us information about the prognosis of this patient and maybe other options. So I hope this has been helpful to kind of give you a quick tour of imaging in heart failure. My just basic summary comments would be, I think you should approach the heart failure patient with informed and targeted imaging, and it's very critical in the care of patients. My belief is that multiple modalities should be employed, and I think at least a paired approach of an echo as a basis for continuing to evaluate patients in ongoing therapy, as well as something to evaluate tissue characteristics or etiology like cardiac catheterization or CT for congenital patients is really that pattern. There's an issue of ischemia and viability. Nuclear imaging is really the standard of care right now, and I think should be also utilized. So it's usually more than one modality, and they should be paired to give you a way forward. And my last comment, remember, it's just a picture. Ordering an echo doesn't cure your heart failure. So you need to know how to use the information, and I think that's probably how our science should evolve, at least as it relates to imaging and heart failure. And with that, I'll thanks for your attention.
Thanks, Eric.